I'm Dr. Grollman. I've been practicing for about 12 years. I work with Lovelace Medical Group now. We work in a clinic just on the corner of Jefferson and Osuna, and most of the work I do is out of Lovelace Women's Hospital. The clinic is its own separate entity, but if we do wind up doing surgery on a patient, usually the surgery is at Lovelace Women's Hospital, but we do also practice out of Lovelace Downtown Hospital, and we also cover the West Side Hospital as well. Just want to get started. We're going to be talking today about incontinence. We're going to focus, and we'll get into this a little bit later, on the different types of incontinence. Main focus is going to be on overactive bladder, but we will be touching on different types of incontinence and things like that. But what I want to get started by saying is it's very important to know that incontinence, more than 50% of people with incontinence have actually never discussed it with a doctor, and we're talking about fecal incontinence and urinary incontinence, and we're here today to try to get that to change. If you've ever had thoughts like, will I ever regain control of my bladder or my bowel? How can I possibly go on a date? How could I ever attend an outdoor celebration or get a job? Or if you've ever had thoughts like, I'm afraid to leave home, or if you're ever thinking things like, the bathroom's always on my mind, everywhere I go I got to think about where the bathroom is, either for urine or for bowels or things like that. Those thoughts are a real concern, and the problem is that a lot of the times people don't get help for these things, and we're here to try to change that. And what we're kind of the kind of the catchphrase of this is a life without limits, and we want to try to kind of get you to feel like a life without limits is possible, and that's what we're here to do. We're here to help you learn how that's possible. So our agenda for today, to try to figure out how we're going to live this life without limits, is we're going to try to understand first about bladder and bowel control. Then we're going to talk a little bit about the care pathway, which is kind of the progression as to how we diagnose, how we evaluate, and how we treat this condition, and just go through the progression of treatment. And obviously, after we talk a little bit about that, we're going to go into some details about the treatment options. And then more specifically, the most important thing we're going to talk about towards the end of the presentation is the MEDTRONIC InterStim system. And that may not mean a lot to any of you right now, but it will in a couple of minutes. And we're also going to talk a little bit about this MEDTRONIC NURO system. And then hopefully at the end, we'll get a chance to do some question and answers. So the first thing to realize about urinary incontinence, overactive bladder, things like that, is that it's an extremely common condition. And you may think that you're having a condition that's rare, or something that's, not easy to talk about, or something that not a lot of people have, but that's not the case at all. They're both overactive bladder and FI, which stands for fecal incontinence, which is incontinence of stool or bowel, are both very, very common. They're actually more common than vision problems and asthma, which is most people think are conditions that are extremely common. And so you can see here in the slide, 1 in 6 adults tends to have overactive bladder, which is about 37 million Americans. 1 in 12 adults has fecal incontinence, which is about 20 million Americans. And compare that to people with vision problems or asthma, and those numbers are higher. And you can see people with vision problems are around 12 million, and asthma is about 17 million. So these are extremely common conditions. The thing is, and what you may be asking is, if it's so common, then why is it often that we don't talk about it, or we don't hear about it? And possibly you haven't really talked about it until now. But the issue is that most people, first of all, tend to self-treat themselves by wearing pads or restricting social activities. And that's partly because of the fact that a lot of people are embarrassed to talk about these things with their physicians. And another reason is that the physicians themselves sometimes don't realize how embarrassing it is to talk about these issues. And sometimes you go to the doctor and they're embarrassed, you're embarrassed. So sometimes the physicians don't ask whether it's a urologist, a GI doctor, primary care physician. Sometimes they don't ask. You never bring it up. So a lot of the times it stays hidden. But what's very important to understand is that this is very common. It's not something that's normal that you should have to live with, and it's something that we can treat and we can fix. So what is normal and what isn't? That's the next slide. So what is normal and what isn't? And like I just said, urinary and bowel incontinence are not a normal part of aging. You may feel like it is, and you may hear a lot from other people. It says, oh, it's just you're getting older and this is what you have to deal with. But that's not the case. So do any of these things sound familiar? Frequent accidents of whether it be urine or bowel. A very common symptom is getting that sudden, compelling urge to have to urinate where you basically have to go right now and you cannot wait to get to a bathroom or you're going to have an accident. Another thing that you may notice is that you plan activities around the bathroom. So let's say you go to a baseball game at a stadium. You have learned that when you go to an event such as that, you know where every single bathroom is, so that if you have an issue, you know where to go. And sometimes you'll plan sitting around a bathroom or making sure that you don't go somewhere where a bathroom isn't readily available. But the point is you're altering your lifestyle around your bathroom activities. Another thing you may notice is that you're monitoring how much you eat or drink to kind of avoid some of these issues. So if you feel like you're getting to that sudden urge to pee and urinate and you can't control it, you'll kind of counteract that by restricting your fluids, which may not be such a great thing. And same thing with bowels as well. You may want to avoid eating certain foods, afraid that you're going to have an accident. And another thing you may notice is that you're needing pads for urinary leakage, or if you cannot get to a bathroom in time and have accidents, you're needing pads for that. So your body is trying to tell you something, and you need to listen to your body. So before we kind of get into some of the nitty-gritty about the urinary incontinence, and the main thing we're going to be talking about is urinary incontinence. We're going to go just a tad into bowel or fecal incontinence, but the main thing is going to be urinary incontinence. But before we get into some of the details, we just want to go over a little bit about how bladder control works. And this, by no means is this a very detailed slide. This is just a very general slide that's kind of, just shows a little bit about the basics of how things work. But the kidneys, basically you can see in the middle of the slide there, the kidneys produce urine and they send urine to the bladder. When the bladder is about half full, it stimulates certain nerves, and those nerves send signals to the brain to tell you to go and empty your bladder. So the bladder-brain communication is very essential for bladder control. And when that communication breaks down is when you have bladder control problems. And those bladder control problems are usually what lead to urinary incontinence. This is very similar slide, basically the same thing, but it deals with the bowels. And what this is just showing the same system but for stool. And basically the way the system works very simply is that the digestive system pushes food through the intestines. When the food and the digestive material gets to the very end of the intestines, which is called the rectum, that full sensation in that area stimulates nerves. The nerves send you to your brain to tell you to relax your anal sphincter, which allows you to have a bowel movement. And again, the bowel-brain communication is also essential for bowel control, and that communication breakdown leads to bowel control problems. Before we get into the different types of incontinence, the question is so if you do have issues with bowel or bladder control, what causes them? And we'll go over a little bit on this slide, and then kind of, but well, I'll talk about a little bit, a few of these, and then kind of go over some other stuff after that. But so what causes incontinence? Daily habits, including what you eat and drink, which makes sense. If you do have urinary control issues, there are certain foods that you could eat that stimulate the bladder in not such a good way, that can exacerbate the symptoms. For an example, just simply is if you do have an overactive bladder, that's very sensitive bladder, that the communication is broken down. Caffeine is something that can irritate your bladder and exacerbate that issue. So that's how something you eat or drink can affect your incontinence. Medications or supplements you take can sometimes affect your incontinence. Reduced physical mobility can affect incontinence. And a big one is pregnancy, childbirth, radiation, or pelvic floor injury. And the reason for that is all of those conditions, pregnancy, childbirth, radiation, pelvic floor injury, affect your pelvic floor muscles, which are very important in affecting urinary incontinence. What the slide doesn't say is that a lot of the times, and I get this question a lot with patients that come into the office because what people really want to know sometimes, not only how to fix their symptoms, but what caused it. But a lot of the times we don't have a good answer as to what causes incontinence, especially when we're talking overactive bladder. Yes, there are some things that put you at risk for it, and there are some things that exacerbate the symptoms. But a lot of the time, this is something that happens as you get older. Now, it doesn't have to be when you're at a certain age. It can happen at any age, but it does commonly happen as you get older. But sometimes we just don't have an actual reason what caused the incontinence. But that being said, the next part of this talk is really kind of just going over the 3 different types of bladder control problems and bladder incontinence. And we'll go briefly, but we're mainly going to focus on number 3. But the first one is stress incontinence. The second one is urinary retention, which is basically not being able to urinate at all. And the third one is an overactive bladder, which is that urgency and urge incontinence of urine where you can't get to a bathroom and loss of control. So what is stress incontinence? So stress incontinence is very classic symptoms of leaking when you sneeze, cough, laugh, exercise, bend, lift something heavy, leaking when you climb stairs. A very common symptom is leaking when you stand from a sitting position. And one of the common symptoms that people describe is having to urinate all of the time just to keep your bladder emptied to avoid having that urinary leakage. Stress incontinence is more related to physical activity. And basically it occurs when there is an increased pressure on the bladder as a result of one of these activities, resulting in a sudden loss of urine. And it's usually, stress incontinence is one of these things that does usually have a significant identifying cause. Usually these things, in men, it's usually a result of previous surgery, like having your prostate removed. And women, it's usually a result of pelvic floor weakening as you get older. But also some other very common causes in women are vaginal deliveries, which tends to weaken the pelvic floor, or previous gynecological surgeries, such as a hysterectomy, which also weakens the pelvic floor. This type of incontinence usually requires surgical correction. There is non-surgical ways to manage it, mostly by doing pelvic floor strengthening exercises, but more often than not, those don't fix the leakage enough to where a patient is happy. Urinary retention is the second type of urinary incontinence that we just mentioned in that other slide. What this is there's a lot of different reasons why somebody can have urinary retention. In men, it's usually prostate related. In women, because they don't have a prostate that causes blockage, in women, it can be caused from other issues, usually neurologic in nature, where the nerves of the bladder just aren't functioning. And basically, the best way to look at a bladder is it's just a muscle. And it's a muscle that's hollow, that fills with urine, and it squeezes. So just like any muscle, if that muscle is weak or not functioning and it isn't able to squeeze the urine out, that can cause issues with urinary retention. And some of the symptoms you can get is when you can't tell if your bladder is full, or if you go to the bathroom and empty your bladder and you feel like you can't get it all out. Another symptom, urinary retention, is when you go to the bathroom and instead of it coming out with a good stream, it's a very weak stream, which is indicative of either the bladder muscle not working or something blocking the bladder. And like I said, in men, that's usually the prostate. Sometimes this gets so severe where the only way to empty the bladder is by using a catheter. The next thing that we're going to talk about, which is the biggest focus of this talk, is overactive bladder. And the very common abbreviation is OAB, which is something you may hear. The most defining symptom is something called urge incontinence, which is a very classic symptom of overactive bladder. And what that is when you get that sudden, I think I mentioned it earlier, that sudden compelling urge to have to urinate without warning. So it's kind of like if you think of a race car going from 0 to 60 in 2.2 seconds. That's what's happening with your bladder. You go from 0, where you feel like you don't have to urinate at all, to all of a sudden having the sudden urge to have to go to the bathroom. And if you don't get to a bathroom in time, you're gonna lose control. This causes frequent leaks, even after drinking a small amount of liquid. And also a very common symptom is having that sudden urge, compelling urge to have to rush to go to the bathroom when you hear running water. Another symptom I've heard a lot of people say is they get that sudden urge when they're pulling into their garage from driving, from coming home from work, or when you hear your keys jingling entering the door. Those sort of things stimulate this severe urge incontinence. And then the other main symptom of overactive bladder is this frequency or urgency combined with frequency. And so this isn't just the urge to have to suddenly go to the bathroom. This is a frequent urination, which is classically described as going at least 8 times per day. A lot of the times waking up at night to have to go to the bathroom. And the other thing is feeling like your bladder is never empty. And that's an important kind of thing to notice, because that feeling like your bladder is never empty is kind of the same thing that we talked about on that previous slide when we talk about a poor communication between your bladder and your brain. It's not that your bladder is never empty, it's that the communication is broken down when your bladder is sending signals too early to your brain that are saying, look, I gotta go, even though your bladder isn't very full. So a common symptom with overactive bladder is having to go to the bathroom suddenly and only small amounts of urine come out because there's not a lot of urine in your bladder to urinate. This is a fecal incontinence, and I'll be straightforward with you. I am not a GI doctor, so I don't do very much with fecal incontinence. The reason why we're just mentioning it here is because the main treatments we're going to talk about that Medtronic has to offer do treat urinary incontinence and also fecal incontinence. But I'm not a GI doctor, so I don't have a lot of knowledge about fecal incontinence, and I'll just be straight with you about that. But what chronic fecal incontinence is it's a recurring condition with frequent accidents, but now we're talking about stool. And it's similar to urinary incontinence. Urge incontinence involving stool is the inability to resist the urge to go and sometimes having accidents. Passive incontinence is a definition of basically the inability to feel when you need to go. So you're actually having a bowel movement and not even aware of it. So the good news is that treatments, we have plenty of treatments that are available that can get you back to living life again. And right now we're going to focus mainly on overactive bladder, and in the process of talking about the treatments for overactive bladder, we'll also discuss how the same condition can also treat fecal incontinence as well. So what are we talking about? There are many ways to treat overactive bladder and fecal incontinence and get back to living life again and getting back to feeling a little bit more normal. But the pathway to this, the care pathway by what we go through, is the first thing is we have to do the diagnosis. So you got to see your specialist, see your primary care physician, see your urologist, and get diagnosed. After the diagnosis comes, when we start treatment, we always want to start least invasive, and I guess invasive isn't the best word, because none of these treatments are very invasive at all, but you want to chart from the simplest to kind of the most advanced therapy. And when we talk about simplest, we talk about lifestyle changes, dietary changes. If those aren't effective, then we move on to oral medications if we have those. And then if the oral medications don't help, which a lot of the times they don't, then we move on to these advanced therapies, which we're going to talk about. So this slide is just kind of going over very briefly about some of the lifestyle or dietary changes that you can do. Simple solutions can help some people, but they may not work well for others. For overactive bladder, the lifestyle modifications are diet, and what we're kind of, I touched on that a little bit earlier. If you have issues with overactive bladder, there's certain foods that you can try to avoid, or 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 certain foods that you need to do more of that could help with overactive bladder. Exercise, I know it's on the slide here, and I'm gonna, the benefit of having me here who's had 12 years of experience is that I can tell you from experience that I've never really seen somebody with severe issues enough to be coming to the physician to talk about it, where exercise has really made a significant benefit. And when we talk about exercise, you can talk about just staying healthy at the gym, but also things like physical therapy, where you can do pelvic floor therapy with a physical therapist, which can help reteach your bladder how to sense certain things, which can sometimes help. If the dietary modifications, lifestyle changes aren't really getting you where you want to be, the next thing that we tend to move on to is oral medications. And for overactive bladder, it's kind of a hit or miss. I'll be honest with you. The oral medications, there are many, many of them out there. Usually the medicines must be taken at least once a day, sometimes twice a day, depending on the medication. Sometimes they work great. Sometimes they don't work at all. If they do work, a lot of the times they tend to not work over time as the body readapts to things. But that is definitely an option. And I will be straight with you, is that I've had plenty of patients that have been on medications and extremely happy, but more often than not, even if they are happy, eventually the medications either stop working over time. But the other thing that people really have issues with is the side effects of the medications, which they're mentioned here. Most of the overactive bladder medications, unfortunately, do have some unpleasant side effects, specifically dry mouth, blurry vision, constipation, and some of them can cause issues with high blood pressure. In the kind of the progression of things, if the oral medications aren't getting you where you want to be, if the dietary modifications aren't getting you where you want to be, the next step is advanced therapies, and that's kind of where we're really going to with the meat of this talk. And in terms of bladder control, the Medtronic company offers the InterStim system and the NURO system as a treatment for overactive bladder if those other treatments aren't getting you where you want to be. And there is also an advanced therapy of injected medications, which we'll talk about briefly as well. For bowel control, as I mentioned before, the Medtronic InterStim system does treat fecal incontinence as well as overactive bladder incontinence. So let's talk a little bit, before we get into the InterStim and NURO systems, let me talk a little bit about the injected medications. And what we're talking about here is Botox. I'm sure most of you have either had Botox for cosmetic purposes or heard about Botox. And basically what Botox is a toxin that paralyzes muscles, which is why when you inject it into the wrinkles of a face, it relaxes the muscles and paralyzes them and takes away the wrinkle. So the same Botox medication has actually been shown to be used in treating people with overactive bladder. The way it's done is in the office, we put a small little camera into the bladder and use a very, very small needle and inject the Botox into about 10 different spots on the posterior wall of the bladder. The effectiveness in this slide says it's comparable to oral medications. In my experience, I feel like it's a little bit more effective than the medications. It does not treat fecal incontinence, which is definitely something to be aware of. Botox, because it's a medication that paralyzes the muscle, it can actually work too well, where it gets it to the point where the muscle is completely paralyzed and you have to self-catheterize yourself. This isn't something permanent. This is something temporary until the Botox medicine wears off, which can take a couple of weeks and possibly months. I do use Botox in my practice in patients that I don't feel are candidates for other things. And in my experience, I've actually never seen anybody go into retention and need to self-catheterize themselves. The other thing that's important to know about Botox is that it's not a one-time thing. If you do have Botox injections, the medication does wear off, and usually it's something that you need to have injected about every 3 months. Next, we're going to talk about a wonderful device that Medtronic has to offer called the NURO system. So this is, again, an advanced therapy for overactive bladder. When you've tried the dietary modifications, you tried the lifestyle modifications, you've tried the oral medications, and nothing's working. Again, in full honesty, I want to be honest. I don't want to say things that I shouldn't be saying. I have not used this in my practice, but I do know the theory of what it does. And basically what it is, it's a nerve stimulation that is actually, as you can see on the picture there, attached to your foot. And what it's actually doing is it's stimulating the tibial nerve. And you may be asking, why would a nerve stimulated in my foot do anything for an overactive bladder? But the bladder nerve that originates kind of in your sacral area, they're all connected. So the sacral nerves that stimulate bladder control travel down the leg and are connected to the tibial nerve. So stimulating the tibial nerve, in theory, is also kind of teaching the body to regain the control of the sacral nerves, which is what helps with the overactive bladder. It's a very simple thing to do in office. It's non-invasive. The stimulation takes about 30 minutes, and you do it once a week for 12 weeks. It appears to be very effective. It's, again, like I said, minimally invasive. And after the 12 weeks of that session, you usually need a maintenance session for long-term relief on a monthly basis. The main thing that I really wanted to focus on in this talk is this Medtronic sacral neuromodulation interstim system. And what this is, again, it's one of these advanced pathways, that advanced therapies that's used when all other treatments have failed. And what this does is it's a stimulation of the sacral nerves. And I guess when we were talking about the tibial nerve stimulation, I kind of touched on those a little bit, but the sacral nerves in the sacral region are drastically important in that nerve communication between the bladder and the brain. And that poor communication is what causes this overactive bladder. And this stimulation has been shown to restore and correct that communication pathway. This great thing about this is that we can actually test this in the office. The way we do that is before, and you can see on this slide that battery, the bigger battery and the smaller battery, that is if you went to an actual implantation of the device. That small battery is what would be implanted under your skin. But no one wants to go and have a surgery if they're not sure if this procedure is going to work. And the surgery to put this device in is very minimally invasive and a very simple thing to do. But what this is this test that we can do in the office. It's a very simple 10-minute test. And if we do feel like this is something that's going to treat your overactive bladder, what we do is we bring you into the office. You would lay down on your stomach on our bed. We would give you a little bit of numbing medicine right into the upper part of your butt cheek. So you'll feel a teeny little pinch. And then after that numbing medication right into the skin of your butt, we put these small little wires just below the skin that stimulate those sacral nerves that this interstim device would ultimately stimulate. So that test is a test that lasts a couple of days. It takes, like I said, about 10 minutes to do in the office. You go home right after the test is done. You would have a wire taped to your skin after that test is done. And over the next couple of days, you see if that stimulation of those sacral nerves and that communication pathway being restored helps your symptoms. And it has been seen time and time again that it gives dramatic improvement of urinary symptoms, better than any of these other treatments that we've been talking about. If the test is successful and you and your doctor move forward, the procedure is a very simple one where the implant is placed just below the skin in your upper buttock, which is exactly where we do the test. And if you do proceed with an implant, there are two very small batteries that go under the skin. Well, one small battery, but there's two different types. One is rechargeable, and one is one that you do not have to charge, and it depends on which one best fits your lifestyle. Saying yes to the test is the first step. I know it seems a little, sometimes it seems a little scary to move away from just taking a medication, or moving away from just the conservative general approach that most physicians, especially primary care physicians, will start you with. But the test is a very, very simple thing that we can do in our office. It's done as an outpatient setting. If you ever wanted this test done to treat your overactive bladder, with our Lovelace Medical Group, the phone number is there to call and make an appointment. And I kind of went over most about this test when I was talking in the previous slide, but it's a very simple 10-minute test. A small wire is inserted to the upper part of your buttock. A lead attaches to a small external device worn underneath your clothes, and it just goes there for a couple of days. And you can kind of see on the picture of that guy, or I think it looks like a guy with a device attached to his back. You will have an external programmer that kind of is like a little cell phone that can adjust the therapy. And after the procedure, you go about your regular activities for the next couple of days, up to 2 weeks, to get a good idea of whether the test is working, and you track your symptoms to see if they improve. This next slide, says it all. It's a safe, and most importantly, it's an effective treatment for overactive bladder. 89% of people using the Medtronic bowel control therapy experience long-term success. 89%. That's almost 9 out of 10. That's better than any other treatment that I've used. And in the same respect, 76% achieve success with the bladder control Medtronic sacral neuromodulation, compared to 49% with medications or other therapies like dietary modification or lifestyle modification. Is this therapy right for you? Well, you may be a good candidate for the Medtronic bladder or bowel control therapy delivered system if, and that kind of what we talked about before, you have significant symptoms of overactive bladder or not urinary retention, not from any obstruction, especially if you're also having similar symptoms associated with fecal incontinence. So if you're having those issues and you've tried things like lifestyle modifications, oral medications, they're not working, you're not happy with the side effects, then this is definitely something that you should consider. If those treatments haven't given you the relief you want, which often they don't, then this is the next step.
Yes, so the number for Dr. Grollman's office is on that screen. It's the 505-727-2727. But if you have any questions, I do see a couple to go ahead and ask you, Dr. Grollman. If you want to ask a question, there's a Q&A button at the bottom of your screen, and you can it's all anonymous. So just ask away and I will address it. If this procedure is so effective, why isn't this done without taking medication?
I'm not sure I understand the question.
If the procedure is so effective, why isn't this done without taking medication? So why do you do the medications first?
Oh, well, that's because medications sometimes do work. By no means are we saying that medications never work. If medications never worked, then we would never try them. There are plenty of times where patients are satisfied with medications. And so kind of what I alluded to at the beginning of the talk, you always want to go with the easiest treatment first. So if you can, this Medtronic system is extremely effective, but it does require a very small surgical procedure to implant it. And those don't come without small risks. So you always want to try the simplest treatment first. with the hopes that it's going to help. And then if they don't, you move on to what's next.
Do you have to wear a battery all the time?
I'm assuming you mean if you move on to a full implant. And so if you do have the test and the test is successful and you move on to having the device placed, then yes, there will be a small battery placed underneath the skin. So you won't be wearing it. It'll actually be implanted underneath the skin in the upper portion of your buttock. But it's usually placed in a spot where you could hardly even feel it, and you definitely shouldn't be able to see it.
I have a spinal stimulator. Would I be a candidate?
That's a good question. And I think sometimes that depends on, because I'm not a neurosurgeon and I don't do those spinal stimulators. So I don't always know the exact information, but that's something that we would have to coordinate between the doctor who put in that spinal stimulator to see where it was put in, to see if it's something that you could have in combination with each other.
A lot of those stimulator batteries are actually implanted in the same location. So we would just go to the opposite side if you were a candidate for it. How often do you have to recharge the battery? So this is the rechargeable system.
Yeah, the rechargeable one, and that is, Heather, you can.
So it's just one time a week, about 20 minutes. When you kind of get in the groove of things, you can make that on your own schedule, but just starting off, you want to do it about one time a week for 20 minutes usually. What are the medications that you would prescribe first?
Well, there's a lot of them. Usually the most common one that we prescribe is oxybutynin. The drug name for that is ditropan. That one tends to have the side effects of the dry eyes, dry mouth, and constipation. There's a medicine there's lots of different medicines out there, and everybody has their go-to medication. There's so many of them out there. Not one doctor uses all of them, but so there's a lot of them. But the ones I use, the main one is oxybutynin, and there's another one called Vesicare. And if those don't work and the patient still wants to try medications as opposed to moving forward, then I would usually try to go to a medicine called MEDTRONIC, which is a slightly different class of medication, which tends to have slightly less side effects than the other medications. And the reason why I usually don't start with that is because usually insurance companies don't allow you to get that medicine unless you've tried the other ones first, because they tend to be cheaper.
Great. Since the presentation was recorded, will the recording be available as a shareable link? Kelly, do you want to chime in on that, just so we know if they're able to share the video?
Yes, absolutely. There will be an email that all attendees will receive, and it will have the shareable link for you to be able to watch after tonight.
Someone said, can I please get this done before December 31st? We're leaving for Hawaii for a few months on December 31st, and I would love to have this corrected before then.
That is doable. It's hard to say whether that would be something we could get done in that amount of time, but if you call that number, it's definitely something we could try.
Okay, please explain UroLift side effect. How long does it usually last? Without
going into details, the side effects of a UroLift for the first couple of weeks are usually increased frequency of urination, sometimes some pain with urination, definitely some blood in the urine for a couple of days and sometimes a couple of weeks. And so basically the side effects are usually that your urinary symptoms get worse for a couple of weeks before they get better. And these side effects can sometimes go away in a couple of days. Sometimes they can last 2 to 3 weeks.
Have you used this treatment on patients who have had their prostate removed?
For patients, yes. Yeah. For patients who have had their prostate removed, usually the issue they deal with is stress incontinence, which is not treated with this, but there are plenty of patients that do have overactive bladder issues after a prostate removal. So if they are having overactive bladder incontinence after the prostate's removed, they'd certainly be a candidate for this. And I can't think of a specific patient, but I do believe I have done this interstim implantation in someone who has had a prostate removed.
So this one's pretty, there was another question about this I had prostate surgery, would this work for me? So it kind of just depends on the test. Same answer, I assume, for that as well, Dr. Grollman?
Yeah, I mean, when you've had your prostate removed, it creates a whole different anatomical situation. So yeah, the first step in that, if you have urinary incontinence, we have to find out what type of incontinence it is. And you know, if you do have overactive bladder incontinence after your prostate's been removed, then yes, this is something that you could consider.
Okay, this one's a little more complicated. I've had deep brain stimulation for Parkinson's disease, which has caused me to permanently need to self-catheterize ever since. Do you have any comment about someone using this treatment successfully or with some improvement? I also have a DBS battery.
So Parkinson's disease is what we call an upper motor neuron issue, which is upper motor neurons are more in the brain. Parkinson's disease can cause a combination of different issues with the bladder. So Parkinson's disease can cause an overactive bladder, but it sometimes can also do the opposite thing to the bladder, where it causes the bladder to be underactive and cause you to go into urinary retention. If basically in someone with Parkinson's disease who has urinary incontinence, again, kind of the same thing as the prostate issue. The first step is we'd have to do a somewhat detailed test called a urodynamics test to find out what is going on. If we find out that you're having to catheterize yourself because your bladder isn't functioning and there's no evidence of any obstruction, then this is something that would be you'd be a possible candidate for. But we'd have to do some testing first to find out what's going on. It's not just a one size fits all sort of thing.
Yeah, there's always, we call it the test before you buy, just like you can test drive a car. This is probably the only therapy that I'm aware of that you're able to do that for OAB. Does Medicare cover the cost of the implant?
I see a majority of my patients have Medicare, and it is covered. Now, everybody's plans are different. They have different copays, different deductibles. So, I mean, I don't always know what exact out-of-pocket cost is, but it is covered by insurance.
I have diabetes. Would this impact any consideration for the treatments available?
No, it doesn't impact. Diabetes is a common cause of overactive bladder because the diabetes affects the nerves of the bladder. The only way I would think that it could possibly affect the treatment is if you had severely uncontrolled diabetes, it does put you at a slightly higher risk of having an infection if you did a small procedure to put in the implant. So if we did wind up having a test and progressing to a full implant, that's something that you would have to be aware of. But usually it's not an issue unless your diabetes is very, very poorly controlled.
How frequently does the battery need to be replaced?
It depends on, I guess you can talk about the two batteries.
Yeah, so the non-rechargeable system, the X, that was the 10 to 15 year battery life. So just depending on the level that you have it set on, that when you don't charge, it lasts 10 to 15 years. And then the rechargeable lasts 15 years, but you have to charge that one on a weekly basis. Then you'll need to replace it at that point. Thanks for the presentation. It sounds like InterStim is not really used for stress incontinence.
Correct. Yeah, stress incontinence is a totally different animal. That's the two main treatments for stress incontinence are physical therapy or Kegel exercises, but usually that requires a surgical procedure called a sling.
What about finasteride medication? I'm not sure I'm saying that right.
You are. Finasteride is a treatment for men with large prostates. So that's not going to be useful in treating overactive bladder. Now, that I guess as I was saying that, I realized that maybe that's not 100% true, because in men, sometimes having a large prostate causes the bladder to have to work hard to push through the prostate, and that causes an overactive bladder. So sometimes an overactive bladder in men is kind of combined, kind of closely related to prostate enlargement. So if patients come into the office with an enlarged prostate and bladder symptoms, one treatment we do is finasteride, which is a medicine that helps shrink the prostate. So basically, we're trying to treat the prostate to reduce its effect on the bladder.
So how do you recharge the battery? Do you have to surgically remove the battery, and does it have to be done in the doctor's office?
No, that it doesn't. No, the battery is recharged with a device that you just place over the skin, and it's done at home.
And if you're going to the trial period, the battery is on a belt around your waist. So you just unclip the belt and you're done. That's done in office. Would this be covered by insurance? And he mentioned that a little bit earlier. It kind of depends on what insurance you have, but you can, if you have anything else you want to add to that.
No, not really.
Okay, I had the UroLift procedure with you 2 months ago. It helped my flow very much, but gave me a bit more incontinence than I had before. Do many folks who have had this procedure do the InterStim?
No, I've never. I mean, usually if you're having prostate issue and the prostate issues are causing the incontinence, the main focus is on the prostate, and the UroLift procedure can treat the prostate issues, but sometimes that still leaves some bladder issues behind, like we talked about, the overactive bladder. Once we are sure or positive or confident that we have fixed the prostate issue, if you do still have bladder incontinence or bladder symptoms, then yes, then we can move on to focusing on the bladder. And usually we start with medications, but if those aren't working, and the next step could be moving on to this InterStim system.
Okay, so along with that, it says if you had a UroLift, can you do an InterStim?
Yes.
So yes. Okay, just a couple more questions, and then we'll go ahead and wrap this up. Is there a test to determine if the prostate is enlarged?
Yeah, there's the two tests. One is a rectal exam, which is it's good. I mean, it gives us a good idea of how big the prostate is, but it's not a perfect test because we can only feel a very small amount in the prostate, so we kind of have to estimate. The other definite test is an ultrasound of your prostate, which is like getting a rectal exam, but with an ultrasound probe. And that way we can measure the exact size of the prostate.
Is the InterStim therapy stimulation painful?
The way I like to describe it is that the stimulation of the nerves should kind of be like putting on your glasses. When you put on glasses for the first time, you notice them, but then after a couple of hours, a day or so, you don't even know you're wearing them. The InterStim stimulation is the same thing. You should notice a tingling stimulation at first, but it should not be painful. And then as a couple of hours or some small amount of time goes on, you eventually shouldn't notice anything.
Perfect. That's what I say too. How long, and this will be the last question, how long is the therapy good for?
That everybody is different. It depends on when you're stimulating the nerves, how much stimulation they leave, but it basically is dependent on the battery life. So if the InterStim device is working, it's good, could be good forever. But the battery life, it does have a certain time frame to it, and when the battery is dead, it will have to be changed.
Okay, well, thank you, Dr. Grollman, for hosting this event with us tonight. It was extremely informative, and we are grateful for your time. And thank you to all of you for joining us. please jot down that number for Dr. Grollman's office that you see on this slide to schedule an appointment. Much of what was discussed tonight is relevant to so many of you, but each and every person is unique. So it's always beneficial to make an appointment to kind of see where you're at and what you can get done. And if you don't mind, please fill out the short anonymous survey once the event concludes. It will appear on the screen and be emailed to you. And thanks again, everyone. Have a good night.
Thank you.
Thank you.